emotional well-being despite that stress. Some baseline resilience is inherent in every person's personality or genetics, but it certainly can be developed and strengthened both through experiences and targeted education so that we can help our patients achieve significant personal growth. And we can use resilience to promote psychosocial health as part of this concept of positive psychology, which is the study of optimal human functioning, anticipating factors that help patients thrive rather than being reactive to disease and maladjustment. There are many factors that contribute to a person's resilience, and they're all interconnected. So I really do like this graphic here. You'll see factors like exercise, self-care, optimism, and social support. And these can loosely be grouped into categories of stress management, managing strong emotions, reframing negative or counterproductive thoughts to positive views of oneself or the task at hand, making meaning of the situation, to figure out next steps, and then also beginning to set concrete and achievable goals to move past the difficulty. And then I want to point out sense of coherence here on the left and spend a moment on that. Sense of coherence comes from the same salutogenic theory about promoting health and well-being. And people who have a strong sense of coherence view their lives as comprehensible, manageable, and meaningful, as informed by life events and the resources available to them. And then this in turn helps promote effective coping, which influences health, and we can measure that using some of these patient-reported outcomes. Sense of coherence is an outlook that helps people respond to stress, which is part of the resilience process. And I wanted to bring it up in this room because back in as far as 2006, Dr. Philip Moons, who many of you know, introduced this topic as a way to support psychosocial health in adult congenital heart disease. In an initial paper, he suggested combating uncertainty with education to promote comprehensibility, helping our patients recognize and identify resources to promote manageability, and helping our patients find ways to help make life make sense so that they feel that life is more meaningful, and inviting them from an early age to participate in their care. Subsequent research has demonstrated that patients with a higher sense of coherence perceive themselves to be more in control over their medical situation, with contributions from many factors such as with whom and how they spend their time, and how they integrate their congenital heart disease diagnosis into their personal identity. And it's this work that created a firm foundation for much of the psychosocial work and certainly the resilience work that we're doing on this topic today. So returning to resilience for the last few moments here, we have personal, clinical, and research evidence that many patients, right, you know this, our patients are resilient, and they generally report similar levels of resilience as other people with chronic illnesses, but those levels of resilience are lower than a general healthy population. And in multiple cases, higher resilience has been associated with better quality of life, which is why this is important. Examples of factors associated with higher resilience in ACHD are better functional status, having achieved a higher education, being married or partnered, and being spiritual or religious across a number of studies, really speaking to the importance of connectedness and empowerment. And I've referred to resilience resources a few times. These are the way that people operationalize their resilience and how they strengthen it. These are what they call on to help them get through tough times. And resilience resources generally fall in one of three categories or buckets here. The first are these internal resources, things like setting goals and managing stress. The second is external resources like community and social support, where that support comes from. And then the third is existential, for example, spirituality and finding meaning in a situation. And hopefully these look similar to the categories I showed you on that puzzle piece slide. And then to what extent people pull from each of these buckets depends on what they need in a specific situation, and also on cultural and societal influences. And we do have evidence that these buckets work in adult congenital heart disease. In an interview study, resilience was pervasive in the way that people manage their ACHD, and they described developing and using resilience across all three of these buckets. In this group, the most prevalent were the internal resources, mostly positivity, goal setting, and self-directed activities like medication or exercise that help them manage their stress. But resilience resources were also talked about from the external category and the existential group as well. So these findings can help us isolate a few skills that we can discuss in the clinical setting one-on-one with our patients if we feel they may be struggling. This is my last slide of content, and I include it here because I think it's a nice visual of how this group of seemingly random topics that I just talked about are all interconnected. So like I said, resilience influences how a person approaches and reacts to an event, like pregnancy. And it influences coping and ultimately how a person experiences stress with implications for mental health and the role of advanced care planning. And then of course here you can also see the social determinants of health are also at play, affecting these processes even further upstream. So thank you very much for your attention today. I hope that I've helped you see the value in considering our patients' psychosocial health and given you an idea of some of the social and lifestyle issues relevant to our patients as they transition to adulthood. Namely, that psychosocial health is equally as important as physical health, that the social determinants of health are pervasive and must be addressed alongside medical issues, that things like pregnancy, mental health, and advanced care planning should be discussed with our patients starting in the teenage years, and that resilience can be a tool to help our patients achieve better psychosocial health. Thank you much for your attention.
Jill, thank you so much for your very important and excellent talk. And we move on to our last speaker in the morning session, Naomi Gautier. She's from Harvard Medical School. She's medical director and specialized in exercise cardiology and cardiac fitness. And she's also assistant professor of pediatrics at the Harvard Medical School. And the title of her talk will be Precision Exercise Dosing in Congenital Heart Disease, a Paradigm to Improve Patients' Outcome. And I hope this time we will have less technical problems. Don't be pessimistic.
The title of the talk will be freaky like that too. All right, third talk. Good morning, everybody, and thank you very much for the opportunity to not only be here in this beautiful environment, but also to speak with you this morning. So my talk is titled Precision Exercise Dosing in Congenital Heart Disease, a Paradigm to Improve Patient Outcomes. But my hidden title is actually Resilience and care across the health span. So I would like to underscore that the lane that I am driving in is this exercise dosing lane. In other words, a prescription or a practical set of tools to use exercise for our patients and drive them with a specific outcome in mind called fitness, which can be defined in multiple ways, which we'll go over later. And not necessarily a talk about physical activity promotion or lack of sedentary behavior. Those are important and will come in, but that's not the focus. Or a talk about sports participation, pre-participation, physicals, or risk of sudden death. That will come in. But this is really about what is our responsibility as the healthcare team to understand the framework and provide specific tools and provide personalized dosing just like you would for a medication. So in order to do that, we'll do a brief look at the current state of physical activity in our youth. This is a youth-based talk, but it does imply the importance going into adulthood. But what is the current state of physical activity in children globally? Why does it matter? In other words, why can we correlate a little bit with patient outcomes? I'll touch on that briefly. And then just like a medication, what are the risks of too much? Too much exercise can be toxic for anyone. And conversely, what are the risks of too little, underdosing? And then how do we know that precision part? How do we develop a framework to understand a personalized dosing and what are some future directions. And if I do this and don't get too distracted or too many stories, it's exactly 30 minutes. Okay, so first of all, exercise prescription is ancient. It dates back to at least Hippocrates, who believed that illness arose from an imbalance within the body rather than from evil spirits and divine wrath. So he taught his students that to be well, the patient must have a healthy mind and a healthy body. It's almost 2,400 years ago. So the treatments he had were aimed at restoring balance, and the first-line treatments were lifestyle factors like diet, exercise, massage, music, art. I think you'll hear that actually this afternoon. Second-line treatments did exist. Pharmacologic or surgical methods were used, but they were just that, second line, and first line were first. Now, somewhere along the line, we started discovering things like microbes and disease processes and tumors, et cetera, and medicine moved to a model of disease recognition and management rather than to restoring balance. And we haven't quite fully moved away from that negative look at health. Okay, told you we're going to look briefly at the global state of physical activity in children. So this is the recent report card for the United States for physical activity in 6 to 17-year-olds. For people who may not know the grading system, it starts with A, that is top grade, excellent, B, C, D, and then F, which is complete failure. A D minus is one click above complete failure. The US is not alone. This is a graph, also fairly recent, of report cards from countries from the European Union who contributed data. And on the y-axis, let's see, do I have a mouse? Yes. On the y-axis is cardiorespiratory fitness, and on the x is muscular strength. In the gray zone, particularly up in here, is ideal fitness. These are just a general population of children. So a handful of countries do have good fitness, but a majority of them do not. D minus. Okay, one last graph. This is a global look at countries that the report card for physical activity specifically for children with disabilities. So the others were general children, these are children with disabilities. So these are the only countries that report data, which is why only certain countries have a color. And it's a little hard to see because it's small, but almost all countries got a D to a D minus. And the only country that got a C plus, which is a barely marginal grade, is Finland, which otherwise got the highest grades for physical activity for youth in general. So even in the best reporting that we have globally, children with disabilities are missing out. We have a lot of work to do. So let's look specifically at congenital heart disease patients. Are they moving? Children with congenital heart disease are put into the category of children with disabilities, for better or for worse. The studies are actually somewhat mixed, which is good because there's a little bit of movement toward the positive. But interestingly, if the physical activity amounts are low, it's equally reduced regardless of congenital heart disease severity, which goes a little bit to Dr. Steiner's talk that once you reach adulthood, or actually I'm not sure if it was both talks, once you reach adulthood, the disease severity doesn't necessarily predict how well patients are doing. Many congenital heart disease remain excluded from activities in sport, and I think that is partly what is seen in that graph of the children with disabilities across the globe. But fortunately, not all are low. There was a 2020 study from Germany of 162 children that showed, to compare to controls, there was a similar amount of moderate to vigorous physical activity and only slightly lower step count. So they were moving, although their peers weren't moving that well either. And there were vulnerabilities, older age meaning teenage age, because this was children, overweight or obese, or complex or more significant findings like Fontan circulation were at risk. My question remains, are they moving enough to affect fitness? And otherwise, are they dosing well enough? They're moving, are they dosing well enough? And how do we know? So one set of data may suggest they're not moving enough to adjust fitness. So this was a fairly recent multi-center study of around 800 children with congenital heart disease, showing that the children in congenital heart disease in orange compared to the peers in green have lower cardiorespiratory fitness as measured by peak oxygen consumption or peak oxygen uptake or peak VO2, which I'll use a lot in this talk. So it's lower than their peers across the age range, and it declines faster, is the bottom graph. And importantly, in adults with congenital heart disease, we see that same accelerated decline in their peak oxygen uptake. So this does not stabilize, or plateau, this continues to decline and get farther and farther from peers. And that's important because that is reversible. It also is important because having a lower peak VO2 itself is associated with a risk for hospitalization, worse surgical outcomes, higher postoperative and later mortality, which I'll show you in a little more detail here. So peak VO2 is only one measure, but it's the measure that is most commonly studied, so we'll use it. And it is strongly correlated with patient outcomes. This graph refers to this top study of adults with congenital heart disease looking at peak VO2 and freedom from hospitalization or death. And it shows here in the worst quartile down on the bottom, if you have a peak VO2 less than 15.5, you have a 2-year event-free survival of 50%. So if you get that number in your patient in clinic, the next 2 years, they have only 50% chance of staying out of the hospital or dying, not dying in the next 2 years, compared to if it's above 27, their 2-year event survival is 97%. Importantly, in the next study, a decline in peak VO2 was also a risk for death and transplant, regardless of the baseline peak VO2. So even if you started up here, if you trend down, you don't keep it up. If you trend down, your risk also goes up. And again, that's important because you can influence that. It doesn't have to stay, or it's not a foregone conclusion that it will continue to decline. There's a tool called exercise that can reverse it. There's not much data in children, and we don't have the same outcomes, length of outcomes as adults. But there is a little bit of data. So this is data from children, happens to be with tetralogy of Fallot, where the expected peak oxygen consumption rise through adolescence was blunted or actually declined. That's abnormal. Through adolescence, both boys and girls will put on more muscle. Muscle consumes oxygen, therefore your oxygen consumption should go up. So blunted or decline is abnormal. There was also a study that we did that looked at pre-surgical patients who were going to be going for pulmonary valve replacement for tetralogy of Fallot, and a peak VO2 less than 70 was associated with longer length of stay post-operatively. So it seems to be a marker even in childhood for worse surgical outcomes. So these things matter, and they're reversible. As a matter of fact, one study that was also recent, 2021, looked at this in a different way of what they called super Fontans. So they looked at patients who were doing exceptionally well. These are adults who had somehow come into their adulthood with a Fontan circulation and were doing remarkably well. They said, why? Who are these patients and what is it? They looked at a whole host of factors, and what came out as number one was exercising from childhood all the way through the health span and lifespan. So my question is, why? Who are these children? Why aren't everybody doing this? And I think it is complex, but we're going to go through some ideas as well as some ways that I think we have a responsibility to influence that. And I think a part of this we have to own, and I think that is because we have to ask ourselves, do we have a hidden bias, not just the rest of the world, parents, the child, the community, all true, but do we have a hidden bias about whether they are capable? Do we truly believe that they are capable? So here's a newspaper clipping from a long time ago showing one of the first patients with tetralogy of Fallot getting a BTT shunt. And the headline says, "Saving our doomed babies." It absolutely, completely remarkable and changed the course of our field to today. And very hopeful, except if you look closely, the word doomed, which means there is no hope. And blue babies are supposed to be pink, that's healthy. Blue is not healthy. So we have no hope for these blue babies, maybe a little bit of saving. And how much have we held on to that idea that there might be a part of them that is doomed? Here's a picture from more modern times. This young man was also born with tetralogy of Fallot. He also got BTT shunt and other surgeries. But somewhere along the line, he had ADHD, a lot of energy, and found a skateboard. And somebody said, "Oh, that's a good idea. Go, please, you're bothering me. Go outside and play." So he developed a skill that he turned into snowboarding and then became one of our most decorated US Olympians in snowboard, which he is doing here, which meant somewhere along the line, someone said, "You must be capable, and I'm not, and I'm going to help get you there," which means his healthcare team had to be there too. what other Olympians are out there, or even if not Olympians as in above the rings here, but their own best self. Are we promoting their own best self as the healthcare team? And I think this is where we have to face the fears. Are they doomed? Do they have a risk of sudden death? So the pre-participation screenings that go into promoting sport, which is not the center of what I'm talking about, but I'm going to talk about it briefly, has actually worked very well, and I think Italy has been the lead in the world for looking at this well. And when looking at personal and family history, exam, and when you have the appropriate interpretation abilities, a 12-lead ECG has been used in order to screen, and the results have been astounding. In a recent study of over 22,000 children, looking at these are just healthy children, 69 of them, or 0.3%, did find a condition with a risk of sudden cardiac death based on this screening, which means lives were saved. In 8 years, almost 8 years of follow-up, only one who had a normal pre-participation screen slipped through and had a sudden event with sports, so on the sporting field, although was resuscitated, fortunately. So the event rate was 0.6 per 100,000 athletes per year, but no deaths, because fortunately we were able to manage the one. A Norwegian study took a different approach. They looked at their congenital heart disease population ages 2 to 18. So this is not looking at athletes or pre-participation. These are just looking at children and how did they do. And they took out ones who had mortality associated with congenital heart disease procedure, surgery, intervention, hospitalization. So excluding those, 19 of these 11,000 patients died, 7 of whom had a cardiac cause of death, and none of them died during physical activity. Interestingly, 2 had resuscitated event with sports. Sports remains a risk. Is it a risk we can tolerate? Is it a risk that we can manage? None of those 3 children out of 35,000 almost died because we managed that risk, but it is still something to consider. However, what about the 34,000, whatever, who need to be supported in their ability to exercise? So the promotion of exercise has become a focus, as it should be, and both European and American societies have come out in support, which I think is fantastic, and I think is a shift. However, the question I have is, are we providing the tools for us to be able to do that effectively for them? So that's where this framework for precision dosing comes in. And I credit the European Council for giving this, which I'll cover in a minute. But the concept is, if we understand congenital heart disease physiology, exercise physiology is cardiac physiology. If we understand the physiology, and then we understand the demands of types of exercise and sport layered on top of that, just like with pregnancy, then we can match the circulation level to the intensity level, and we can guide a dose that will work for that individual patient. And then we can find ways to promote activity, including modification of sport if that's what they want to do. And we can get at that information partly from the ability to measure oxygen consumption. So oxygen consumption, this is for people who might not be familiar with this graphic. This is 2 slides worth of an entire year of curriculum of exercise and cardiac physiology, but briefly, this shows how the complex interplay within the body yields our ability to exercise. So the initial 3 gears down here were depicted by Karl Wasserman, who's a famous exercise physiologist and pulmonologist, that shows here at the mouth, when you're intaking oxygen or uptaking oxygen, it has to go through the lungs, has to go through the heart, down to the muscle, and be used at the mitochondrial level to produce ATP, so you have energy to exercise. That has a byproduct, CO2, that has to reverse that and be exhaled at the mouth and produced. So by measuring oxygen uptake and CO2 production, we can understand an elegant amount of things that happen within the body, including the heart's ability to support this whole circulation and to support itself, in other words, coronary flow. I added a 4th wheel, the brain, because the brain does oversee this process. And I think that's important when we think about things like promotion and resilience. So the brain here has, in this schematic, an enlarged cross-section of the brainstem. And there are numerous receptors, stretch receptors in the lungs, irritant receptors in the lungs, receptors in the muscles and joints to see about hyperextension, all sorts of central and peripheral chemoreceptors. And then there's higher cortical responses, including emotional stimuli, ability to feel pain, and then prefrontal cortex structures that are assessing the cognitive understanding of all these inputs. So in other words, there's checks and balances that are built into the system that are watching those gears so that we don't push ourselves like the original marathon runner to the point of exhaustion and death. Our patients have this too, but I would say that at least in personal experience, the main thing is cognitive misinterpretation, because all of these signals have to be interpreted by the brain of what does that mean? Is that good or bad? And I don't know about others, but I think most of us are taught when they come to clinic, you ask things like, are they short of breath? Do they feel their heart race or pound? Do they feel sweaty, lightheaded? And what happens when you exercise? Short of breath, heart races. So how does the brain know that what they're feeling is actually healthy versus a sign of danger? And that is our responsibility, I think. Okay, so getting deeper into a paradigm of how we then translate that to tools that the patient can use. So again, I credit the European Council, some of who we have here, with really a beautiful shift in paradigm to think away from anatomy and toward a hemodynamic approach to thinking about the demands of exercise. So in 2013 was the article looking at exercise prescription based on this model, and then in 2020 looking at sport. This particular graph comes from the sport one, but is similar for the exercise, just a little simpler to put on the slide. But the idea is that you look at physiology in terms of ventricular function, pulmonary artery pressure, aortic size, arrhythmias, and oxygen saturation. And based on all of those variables and a chart I'm not showing you, you can then categorize into the other sections, and then you can provide, I think, pragmatic advice to the patients about what's healthy. So we took that and utilized that, adopted that, and made a few additions when we started to think about how do we provide a specific exercise prescription for our patients who are getting supervised exercise. So we started a cardiac rehabilitation, we call it cardiac fitness program for patients with congenital heart disease. But there was no paradigm for risk assessment like there is in adult cardiac rehab. And so we had to look somewhere. So we adopted it, and in brief, it follows essentially the same guidelines: function, oxygenation, rhythm issues, complex, including aortic size, and coronary issues, and then elevated load like systemic hypertension, pulmonary artery pressure, and then diastolic dysfunction. And based again on specific clinical parameters, and we have a chart that you can look at, you then categorize each one by risk, and the single greatest risk gives you then this force category, which drives a specific exercise prescription by intensity level. So based on that, you can then start to drill down on a patient's individual level, just like you would with, say, any medication. So for those who may not be familiar, there is a standard way of training to get fit. This is true for all of us, and it's called FIT-VP. It stands for frequency, intensity, time, and type, and then volume and progression. And based on those variables, then you can actually start to develop something specifically for the patient. So frequency is typically 3 to 5 days a week. It's a little bit like Coumadin dosing, right? You know approximately what you want to get to, and then you check to see how they're doing. The intensity would be by their hemodynamic profile that we just went over. The time actually depends on training type and style, but even 20 to 30 minutes can be beneficial if it is done within the appropriate training zone. If it's too little, you're not going to get there. If it's too much, it may be dangerous. In the training zone, you're going to get results. True for us too. The type I feel very strongly about, and this is going to tie in very well with Dr. Steiner's talk. We feel there's 4 pillars of fitness. We actually recently published on this: aerobic strength, flexibility, and mindset. All 4 will require training, and all 4 are modifiable. Aerobic, to do aerobic, get better aerobically, you do aerobic work. For strength, you do strength training. Flexibility, the same. To get a stronger mindset, just like any muscle, if you will, you do exercises. There are specific exercises to train in optimism. There's specific goal setting. There's specific confidence building, et cetera. Those are built in to this whole system. And then the volume is all of those in combined, again, like Coumadin dosing, and then you progress as you grow, just like you do in any task or education, you start and you build and you grow. There is 40 years of data showing that exercise training improves both physical parameters like on the cardiopulmonary exercise test and quality of life. This works. Our hidden agenda, maybe not so hidden agenda, is that wherever a patient can go across all 4 pillars, we want them to reach their best self. And so our motto is Find Your Possible, that you see on the back of our t-shirt, because that is our ultimate goal. Whatever that is, are we pushing our patients to that level? And how do we get there? Because the benefits of exercise are far-reaching. And so while we do have to acknowledge that there could be some risk at high levels, if you are not participating, if you're underdosing, you don't get these benefits. And that is something that really worries me, because we saw the graphs about children with disabilities moving around the globe. So the health benefits, I even ask my little kids, why is exercise good for you? And they say it's good for my heart. Well, of course it is. But it's also good for lungs, bones, muscles. We saw that it improves peak VO2 and has better outcomes. There's also a cascade of immune responses you saw on an earlier slide, how important it is to combat chronic inflammatory responses. And exercise actually reverses those. And it affects nearly every organ in the body. We have a tool at our disposal to improve the vulnerabilities of our patients. It decreases anxiety and stress and improves mood, which is another vulnerability. A lot of these are looked at toward promoting future health. And I just want to pause for one important slide to talk about now health for our children, because I think that it gets lost in the idea that you will grow up to have less chance of obesity, less chance of diabetes, less. But right now, if you are not participating, you don't get these benefits, which is improving focus and attention. It's been shown in many studies. Here's a quick view of one that shows children in blue who did an after-school program compared to peers in red who did not, after-school physical activity program, that their attentional ability went almost to normal by engaging in exercise. And then this is functional MRI. Their brain activity went to normal just by participating in exercise. Exercise also helps brain plasticity, which is very important. It's actually a whole talk just in and of itself. Probably, or at least partially through blood flow from exercise, as well as the promotion potentially from the blood flow signaling of BDNF, which is a neuroplasticity factor. It also helps with development, and by the way, I put physical activity and exercise and play in here because I think that they're intertwined. It helps with cognition and school success, not just attention, but actual cognition. I tell my patients that exercise makes them smarter. It's true. So they have better scores across the board. Importantly, it helps with classroom behaviors and regulation. If you are not regulated, what happens? You're disrupting the classroom. If you're disrupting the classroom, neither you nor the other students can learn, and most commonly, you get removed from the situation. If you are not present and included, you are not getting the benefits of the education, and exercise helps to reverse that. And then lastly, maybe not even so lastly, additionally, empowerment. Exercise gives people a sense of body mastery and empowerment. And that is my holy grail, to see if I can figure out how to measure that. Can we have an outcome measure that looks at that ability to feel like you can, not that you can't? So I'm going to try and play this. I don't know if we'll get the audio, but we'll try. This is one of our teenagers who went through our fitness program, and I'll let you listen in his own words, hopefully. Hopefully.
Before I used to never really do anything because I was like, oh, I have a heart condition, I can't do anything anymore. But now I realize there's a lot more I can do. I was just scared of the possibilities.
I don't know how loud that's going to be now. So I'm not sure if you heard that, but he said he didn't used to do anything because he wasn't sure, but now he knows he can do anything. He had just previously been scared of the possibilities. So that sense of what's possible is what we're driving for. And I think that's really important, so I'm going to do a quick diversion into positive expectations. And this really, I think, speaks to anticipatory guidance and to resiliency training. But this is work from the 1960s from a psychologist named Robert Rosenthal. And he took 2 strains of rats. One he called maize-dull. They were a strain that were not very bright. And then one that was a very intelligent strain. And he brought his researchers in, And he had them run through their standard maze to get baseline data to see how intelligent they were and how well they learned. And indeed, the dull ones didn't learn well, and the intelligent ones did much better. The important thing was there was no difference between these rats. They were the exact same rats. He just put them in different cages and put a sign on the cage. So the expectations of the researchers was transferred to these rats. They literally did better. They did learn the maze better, were smarter, but not because of an intrinsic genetic reason, but because of the expectations of the people handling them. So he then took that into the elementary schools, and he brought an IQ test and the Harvard Aptitude Test in the beginning of the school year. And he gave it to the students, and then he found a group of students who were designed to be what he called spurters, or they were going to grow and blossom. They had potential versus the regular students. And he didn't tell the kids or the parents, but he told the teachers, these children are going to spurt. And then he came back at the end of the school year, and this is what he found. The light gray are the regular students, and the dark gray are these ones with potential. And the IQ score gains from beginning to end of the year were much greater in these ones with potential. And you know where this is going. There was no difference between these children. There was no such thing as the Harvard Aptitude Test. He made it up. What happened was the expectations of the teachers were transferred to these students so that they then did well. My question is, are we doing that for our patients? Are we giving them those positive expectations? Positive expectations is not saying that there's not other things coming. I think a little bit like, maybe use a sports analogy, if you were going to have a play on the football field pitch, soccer pitch, and you knew that there were going to be defenders, you wouldn't just say, these are the obstacles in your way. Your goal would be to say, here are the obstacles, but your goal is to get a goal. How do we do that and navigate? Challenges will be there. How do we navigate through them toward that goal? Optimism, as one of these key factors that is modifiable, as you saw earlier, has been studied. Actually, a lot of these have been studied. So here's a quick one in adults looking at not congenital heart disease. These are adults with atherosclerotic disease. And it turns out that when you look at the degree of optimism across almost 230,000 people out of 15 studies, that optimism correlated with reduced risk. Look at that graph. It's not even like slightly overlapping. Significant reduced risk of cardiovascular events by having greater optimism, which is trainable. The same thing with all-cause mortality. You are less likely to die. Are we providing that from early on? So my last, hopefully you can hear this one, my last video, and I'm almost done. This is a little boy. I founded and ran a camp overnight camp for children with congenital heart disease. And that's where this is from. And the whole point was to get these children to think, not I can't, but I can. And this is a boy with Epstein anomaly who was quite affected, and his echocardiogram does not look good, but he looks amazing. So I'm going to play this.
It was so hard because it was like, should I go on, should I stop? And when everybody cheered, you can do it. And I was just like an inch away from the top. I'm like, I can do this. And I hung on, and I just was so happy when I got to the top, because last year I got to the middle, and then this year I finished it off. So I'm very excited about that.
So I would argue that he has found his possible, and that came from his parents, from his healthcare team, from people encouraging him, and then from the social connection that he got from the children who were encouraging him along the way. So that is briefly a paradigm that we've been working on that look at combining physical activity, that sense of body mastery, the mental skills, and sense of autonomy, and the social connection, which, if anybody knows social determination theory, are the three pieces of social determination theory, which are the best to make you well through life, through this positive fitness, not positivity, but setting expectations and navigating challenges with a positive goal in mind. What is your best self? So the exercise dosing, precision exercise dosing would look something like this: assess clinical and hemodynamic status, think about their goals, their hopes, their dreams. I actually ask that of our patients. develop an exercise prescription, and then track metrics. And there are a host of metrics, which I'm going to skip, that I think we don't yet know. So just to conclude, if we look at exercise as a way to generate fitness broadly, it's crucial to cardiac success and to childhood success, which is crucial to adult success. It needs to go beyond promotion to prescription, and that sound paradigms really do exist to guide intensity, but little is known about specifics. So our dialogue in our field overall needs to shift towards studying precision dosing, to investigate what are those specific inputs. There is some risk, so we have to think a little about, do we know dosing well? How can we track relevant outcomes? Are we getting what we want? And are we setting the right positive expectations? Because I think that we would reveal undiscovered possibilities in our patients. I know I've been surprised by them, and I cannot wait to see what blue sky is ahead for them if we allow it. Thank you.
Thank you, Dr. Gauthier, for this excellent talk and highlighting to us how important it is to fine-tune exercise and what positive effect we can get with this. Thank you. So we have the advantage of having a very experienced audience here, and I'm really sure that you will have some important questions to the three speakers. So the discussion is open.
Thank you very much, and good morning, everyone. My question and my comments are for Dr. Gauthier, and I'm Alessandra Frigiola. I'm an adult congenital heart disease consultant based in London. I've been there for over 20 years. So just to say the background, because I think it's different what you do and how you approach the patients based on where you are. So first of all, thank you for a fantastic overview. I really enjoyed that. Couldn't agree more. And being an adult congenital consultant, I see the other end of the spectrum where they are adults. So my comment, I have a comment and a question. The question is, first of all, it's a multidisciplinary approach to these patients. And so what team do you have in place and what resources do you need to put into place these kind of programs, first of all? And then the second comment would be, when we are in the adult side, it becomes really, really challenging and tricky to change the lifestyle if we want to, because motivations is not there. Patients might have family, they don't have time. And I tried for 3 months to give patients the opportunity to have a one-to-one session with a physiotherapist or exercise physiologist. They had a diet given to them. They have a personalized exercise program. The uptake of the program was really, really poor. And then you realize that you need education, and it has to start really early on when they are children, and the family is a big part of this, because they need to let them go, they need to let them exercise. And so it really opened a big, big issue. They have no idea what diet is, they don't know what to eat, and so you really understand that they need a psychologist to help them overcoming all the barriers they have. You need a dietitian involved, you need a physiotherapist, and then you need gadgets that help them as well, tracking their own improvement, if you want. So the question for you, how is your team organized, and how do you do this from a very young age? Thank you.
Thank you very much. And apologies, because it's our fault in pediatrics that you're facing your issues now. But hopefully that will change. So to answer your question and then to comment on your comment, we have in Boston a very richly resourced team, but you don't need it. I really believe that, and we are trying to actually develop tools that will allow low-resourced or even high-resourced, but being more considerate of resources to achieve it. So our team happens to be we have 10 exercise physiologists, which it translates slightly differently around Europe, but people trained in exercise testing and exercise therapy. We have a whole cardiac neurodevelopmental team to address the related issues that is outside of our program, but Boston has a big neurodevelopmental program. And then we have physical spaces that allow us to bring the patients in for exercise. So we have 4 different dedicated space and an inpatient space. And then we also have the ability to use telehealth to supplement. We specifically designed our program without using any physiologic monitoring, so no fitness trackers, because we wanted to plan for optimal resource utilization, but some people use those also. The appeal is there, but it needs to be scaled in the right way. I firmly believe, and we have worked with children as young as 8 up through adults in their 50s. So we have taken all ages, and they all come in with a similar, I don't know if I can, and we can see that change. And I really believe that it boils down to teaching them physical activity, providing them the mental skills, and giving them the social connection, even if it's through the physiotherapist or the healthcare team. So it doesn't require equipment. You can have no equipment and just a small space and use your body. It doesn't even require any fancy tools. It just requires, I think, a big piece of social connection, and then the resiliency additions, and then the training follows. So while we are resourced and we're trying to use those resources to then play with how it can be scaled, I really firmly believe that it doesn't take very much to make a huge difference in whether somebody feels empowered. Yep. 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 So some of the consistency, I think this is where some technology can be helpful. So we're in the process of trying to develop an app-based version, not to replace human connection, but to augment and have a place where it can be a consistent measure so that you can have the resources that are the human resources spread farther or scaled by augmenting with technology. Even if it's just all you need is a way to connect, it's at least a start until we start training ourselves and our parents and our communities from childhood on, and we have less to worry about in the future.
I want to make a quick
One
comment.
additional comment from
Yeah,
Anna
from the
Trainer.
adult side. At Stanford, in Palo Alto, we sit in the heart of Silicon Valley, so we can be considered resource. But I recently gave a talk to a county hospital about exercise. And one of the things I want to say that makes adults unique, all is not lost if the seeds are not sown, or even if the seeds are sown, there's a different autonomous person emerging in adulthood. So I think the key is motivational interviewing, just like we would do with, hey, you want to stop smoking? We don't just tell them stop smoking, right? We kind of get in their heads and say, what is it that you like about smoking? We ask this heretical thing because we want to understand where they're coming from. And so what I do with my patients, and I can do this with no resources or tons of resources and a cardiopulmonary exercise test and whatnot, but I think in the exercise prescription, after doing motivational interviewing and making sure that you follow up at each visit. So what I teach my fellows is, this is not a one and done. This is every single time. And what I tell my patients is, you must be doing well because we have the luxury to talk about lifestyle. I did have one pediatric cardiologist, heart failure, tell me, I think it's pretty much useless, Anitra, for you to be doing this for adults because, once they have this decision in their head that it's not possible. I'm so glad I still maintain what is possible. And our adults can do that too. We just need to get in their motivation, figure out why. And then the second piece of not tracking is there's very validated tools for rate of perceived exertion. And what I tell my patients is, hey, mild exercise, you can talk and sing with your friend. Moderate exercise, you can talk but not sing. And at high intensity exercise, you can do neither, and I'm running from a bear. And just giving them that time and space to know that they don't need the fancy tools. They can use the fancy tools, of course, but they don't need them in order to have that success.
Thanks to the panel. I'm thinking about an adult patient evaluated 3 days ago. Could you consider the condition of those operated for aortic coarctation in which the possibility of recurrence is frequent? The physical limit is, in my opinion, even with the same pressure gradient, a dynamic condition, and indeed the response to exercise can be the first sign of an evolution of the pathology and therefore an alarm bell. What's your opinion in this case? Thanks.
So if I can rephrase the question, you're asking if we have a patient that's at risk for recoarctation, how do we encourage them to exercise, or like what are those parameters? I think one of the things I'm learning from both of my colleagues here is, one, about that cog called the brain, and driving all of those things, so really educating the patient on what things might feel like, and two, what the resilience may be once that is started. But getting into the nitty-gritty here, we use exercise-induced hypertension and cardiopulmonary exercise tests specifically in patients with coarctation, because as you know from the systemic hypertension literature, there can be a hint of when blood pressure can exceed 205, 210 in males and females at peak exercise. That can be our hint of arterial stiffness. And we use that then as a means to prescribe ambulatory blood pressure monitoring, either in the fancy form where you take it home and it looks for the dip in dippers and non-dippers in terms of blood pressure fall, the natural blood pressure fall at night, or we just have patients keep a blood pressure log at home under various conditions. So I would not limit exercise in that situation, but it gives me a hint as to, let's go back to the drawing board. And there actually is some data in our coarctation patients to say, or those with LV dysfunction, or those with a systemic right ventricle, to say maybe we should drive those blood pressure targets, not where JNC7 says 130/90, but perhaps we should do a 120/80 approach and really drive that blood pressure a little bit lower and say, we'll prescribe this small amount of blood pressure medication, retest, and see what the peaks look like.
Of course, and then I think there is also that empowerment component to it, giving our patients the tools they need to recognize what safe exercise feels like, what good enough, adequate exercise feels like, and when perhaps they might be pushing themselves a little further for one reason or another. So really making sure that we're doing the kind of measuring on the medical side, but also translating that into data, a feeling that our patients can track themselves for how they're doing in the effort to empower them to push the boundaries a little bit further, but still helping them feel safe.
Thank you very much. I enjoyed the talks this morning, and I developed an interest in this topic through Gigi Festa, is almost sitting next to me, who is talking this afternoon. Dr. Garcia, you cited the Italian experience and so on, and the Italian experience might be wonderful, as you say, but it basically makes sure that there is nothing happening on the sports field. So actually the patients at risk we're talking about here in this session are excluded from these numbers because they're not allowed to participate. Now, obviously what you're saying, if I understand it right, is that the benefit of physical exercise very much applies also to those people who actually have risk of sudden death. And so, I mean, the ill population is benefiting. And I think here in Italy, it's actually quite a legal challenge. I mean, so children are not allowed to do sports because nobody wants to take the responsibility over that risk. And I just wonder how that is in the United States. I mean, who is kind of willing to take those on who have a risk but would also have a benefit? It's unfair not to give it to them.
That's an excellent question and complicated. Thanks. So I'll answer that in a couple of ways. First, just to touch on the risk with sports is different than the risk with not sports. And that's why I presented the Norwegian study that looked at, do these patients die? And very small number of patients with congenital heart disease die outside of operating room, hospital, and none of them during physical activity. So just to underscore that. Now going back to the sports question, it is different in the United States. We do not have the same legal pressures. As I understand, I don't know the situation exactly here, but I understand there's different legal pressures here. So the model in the United States has tended to be a little bit of more what we call shared decision-making, meaning that we acknowledge risks, have conversations with the family, sometimes the school or the sporting club, who is going to also be assuming some risk, and make sure that everybody is in agreement, and then allowing participation based on that, trying to move away from the model that the healthcare team has some sort of right of yes or no, and that it should live with the healthcare team, and having it be more of a shared model. So that's our fabric, which is not the same, as you say, around the world. So I think the complexity comes from my angst about whether we are doing right by the majority of our patients and promoting them well. When we get to the sports and competitive sports level, we're talking about a small number. That is something that needs to be tackled country by country. And I do believe that is something that we as a healthcare team have influence over. But it's not something that I can speak as well on as shifting that lens a little bit away from your question toward can we ask ourselves, are we doing well enough to adequately promote and provide resources, whether or not they're expensive or free resources, but providing resources and believing in our patients and giving them that exercise prescription if they're not doing sports. If they're doing sports and want to, they are naturally inclined to exercise, and they have some talent, and there are safe ways to do that. But that's complicated. It's just a small number. So something that I believe very strongly in, but I don't want to lose sight of all of the ones who are not interested in doing sport, but need to be doing something. And everybody can do something. It's just a matter of how much. So I don't want to confuse that by focusing too closely on the competitive sport environment, because that is complicated because it involves the concept of responsibility and who owns responsibility, and that's a social construct. Did that answer your question?
May I add a comment, because I was chairing the sport cardiology session at the annual meeting at the APC in Porto this year. A lot of things have changed, and we always have to divide between sport and competitive sport. And there exist some risk stratification papers which are very useful, and almost 90% of all kids and young adults with congenital heart disease are in the meantime able and allowed to do sport. But sport is not competitive sport. Of course, for competitive sport there are restrictions, but the normal sport is more or less open for nearly 90% of all the kids. And that's a big difference. Of course, we are in Europe, we try to find recommendations for the whole continent, and there are different legal aspects, but we agreed in Porto that nearly 90% of all kids are allowed to do sport in any way. And there has been, and that will be the last comment, there was a big change in what are the kids allowed to do, which sport, because until this year we always asked them, encouraged them to do endurance sport, and this has changed as well with the new AC paper.
I enjoy a lot this session. I would like to thank all the participants. And taking from the Philip issue, I think that to overcome the problem about the prescription of sports. I think we have to pass the idea that sport, as you said, very beautiful, sport is a therapy. So as we give medicine, beta blocker, aspirin to patients with some advantages, also with disadvantage, exercise is a therapy. So we don't need prescription, how do you say, the certification. So we don't, when we give aspirin to people, we don't need certification. Why we need the certification to have sport? This is, I think, the message we have to give.
I totally agree. And there's one other question from Francesca, please.
Yeah, thank you very much. Yeah, my comment is just the following part of what Gigi said, because, sorry, we are focused on Italy, as Philip introducing. Italy is a really peculiar situation, totally different from all other countries in Europe. So when in APC we speak about Europe, Europe is one thing, Italy is another one. It's true about everything, because sports certification, as Gigi said, is a real problem, because when you say competitive and non-competitive, you are totally right. The problem is that now in Italy, since 9 years old, you need a competitive certificate to do football. So this is the problem. It's a legal problem. So it's not, no matter what is real competitive or not, because all you said is absolutely right. The problem is that in the real life, we have a totally defense medicine in sport issue. Sports medicine is a totally different branch of medicine in Italy that does not exist in other countries in Europe. So we as cardiologists, we are not able to certificate a patient. I spent pretty all my life in France, and we as cardiologists, we certificated our patients to do competitive or not competitive. I'm not allowed in Italy to do it. So the sport doctor, that is a totally another category, they have their legal regulation, it's called coaches, and the coaches decide every 3 years what is allowed and what is not allowed. We don't have a word about. And especially all sports societies now are more and more asking for competitive certification. You can understand that for a 9 years sport boy to have a competitive certification is a totally absurd. So this is a real, practical problem and not philosophical.
Unfortunately, we can't solve your problem.
Can I ask one question? Going back to what you were talking about, both Anitra and Joe were talking about earlier, of cardiovascular disease, adult-type cardiovascular disease being a higher prevalence in our patients who've become adults. Why is it just inflammation, or are there other things? Are there genetic issues? Do we understand why there's such an increased prevalence?
Yeah, certainly I think the thing we know most about is that inflammation and just the chronic sedentary nature that we've instilled in our patients because of conversations like this. And then also this belief that somehow they will be at risk if they are active. I think those are kind of that sets the foundation for this metabolic syndrome, which yes is inflammation driven, but it's not just that. And then of course there are also contributions, genetic contributions for familial hypercholesterolemia, for example. Some of the syndromes that we see in congenital heart disease also accumulate a higher risk of acquired cardiovascular disease later in life. So it is multifactorial, but I believe led by inflammation.
One of the interesting things that our group did in looking at the UK Biobank data is just kind of understanding why, asking that exact question. When you correct for lesion, when you correct for all of the other things, of course, it's difficult to correct for everything when you do database work. Just as you said, what can we ferret out? And so maybe putting in those things now and then check back in another, decade or two and see how we doing, But it can be difficult there to understand, is there something intrinsic? Is it, and we say inflammation, but what do we actually do about that? And certainly exercise itself and lifestyle changes induce its own type of inflammation that may be positive with respect to the other bio feedback and the other types of things that are released in the body. So I would say I remain very much a student, and I try to do whatever risk factors I can modify, but I truly won't know, I think, until making this step change and then waiting for the data to come back.
There's one question from the young lady close to Philip.
Buongiorno, good morning, everyone. I'm the less experienced here in this room, so my intervention want to be just a really, really big thank you to all of you, because I just graduated from medical school, and I just want to say that during my studies, what I saw is that the importance of quality of life when you approach this to a patient, it's often the last line. So also during the exam, if you say every lines, like everything you have to do when you analyze a patient, if you don't mention quality of life, it's fine. Like you will get a higher grade. So I really want to thank you, because this was really enlightened for me, and I want to ask to everyone in this room, if you are a professor, if you have the chance to teach to the younger generation, please stress this importance of quality of life, because it's not, I think, enough mentioned in the class and during practice and during our education.
Hippocrates would be proud.
Yes, thank you for that comment.
Yeah.
And it does speak to what we were talking yesterday a bit about educating kind of the next generation and thinking about how we approach the whole health of our patients as we now are moving into a new era of our patients living longer, and really helping them support them through that process of living longer and how to do it well. Thank you.
I think the final question will be by my co-chair.
No, I mean, thank you very much for that comment, and I just want to make a comment and have a question coming from the pediatric side, because it was mentioned that maybe we don't ask the right questions, or I mean, we don't see that burden of disease in the pediatric age. But what do you think we could do? And I mean, besides transition, do we have to start earlier? And what role are the parents playing? Because we see a lot of parents who really overprotect the children, and maybe is that having an influence on the resilience of the children and then the later adults?
Yes, absolutely. There are studies that have shown that an overprotective parental type does blunt children's and adolescents' resilience with congenital heart disease. And so really supporting the parents, as you're used to doing, I think is a huge piece of that puzzle, and helping not only the patient understand their risk and ability and empowering them to live their lives despite their congenital heart disease. It also includes involving the parent and helping the parent have the confidence to let go a little bit, and not to drop them off and not be there for them, but to really be there to lift their child up, particularly to progressively increase their independence as that child grows into an adolescent and then young adult that is able to take on and participate in some of those discussions. So really absolutely involves parental education as well.
If I can make one additional comment, I think that is an excellent question, and that's why I take responsibility as a pediatric cardiologist toward what happens when they become adults. And I think some of it really boils down to the language that we use, and how we use language. Do we talk about risk assessment, or do we talk about anticipatory guidance? They're really the same thing. They're just said differently. If you think about congenital heart disease, why do we call it a disease? A disease is something that makes you sick and that you can't ever get over if you are born with it. So are we sending the right message from fetal life? Are we using the right language? And can we think very carefully as a healthcare system about whether we are using our language to promote hope and optimism, not to ignore challenges, but to put them into context, because then I think our parents will have better context, and their children will have better context, and we will have better context from the beginning.
I totally agree, and I would like to make a final comment, as I'm not just a pediatric cardiologist, I'm a pediatrician as well. And we have to know physical activity starts at the moment when we are born. And it becomes more and more important because our kids spend hours and hours using mass media. They get obese. We do have a lot of problems with arterial hypertension. So we have, and there exist a lot of recommendations national-wide, and we have to start and we have to encourage the parents that physical activity starts within the first minutes of life.
I think that's a great point. And one thing I often do, and I think you have the power to do in your office, is really involving the parents. I mean, we do spend a lot of time trying to individuate in the single ventricle clinic when I see adolescents. But sometimes I take a different approach because I can see that there's this tight bond there. And I say, let's talk about exercise. And I bring in the parent too, and I let them stay in the room. And I just get an idea of what is the prevailing attitude. Because even if we instill certain ideas in the kid, and let's say it's safe and whatnot, if we return them back to the environment, which is largely sedentary, we may not get the answer that we want. So again, understanding the community from which they come. So if the family can, sometimes I can promote, do you guys ever do a family walk? Do you guys ever do a walking after dinner? You know, talking about those things where you have the family right there. So why not harness it? I really don't think that that's bad, because we're saying, hey, let's bring everyone along, not just the patient.
If there are no,
An issue that has been raised by the mom of a 19-year-old that died suddenly. She had an arrhythmogenic right ventricular cardiomyopathy, and the girl was very active. I think she was a Cambridge University rowing team, and she had a syncopal episode first. She had an ECG, discharged from the A&E, and actually the ECG wasn't normal, has been reported as normal by the A&E consultant, and then a few months later she died suddenly. Now the mom of this girl has been, is really moving mountains and everything, trying to implement in the UK, and I'm really ashamed to say the UK does not have a screening program for athletes, not even elite athletes, apart probably football. And so my question is, what is the screening that you put in place in the US, and how do you overcome the problem of cost as well? So Italy has a program, and this mom is now in touch with Italy, trying also to get information of how we can translate in the UK. But I can give you an example. American football players, and you well know how intense is American football, Premiership athletes have no screening whatsoever. And this is appalling. And so there is absolutely nothing done prior to participation. So what's the program in the US, and how do you cut the cost?
So I'll keep this brief. There are pre-participation guidelines in pediatrics by the American Academy of Pediatrics, and then through the sporting world, through the American College of Sports Medicine. And then there are also sports cardiology guidelines through the ACC. So those are all American societies that have guidelines that are easily accessible, that give guidance very similar, actually, history, physical, plus minus ECG screening to try to find hidden risk.
there exists a paper of the APC. So there exists recommendations for pre-participation screening in Europe as well. If there are no further questions, I would thank all the speakers and the audience. And I have to ask Umberto, when do we have to meet again here? Okay, 20 minutes, and it's time for us to stand up, to move, because we had a long morning. Thank you.
Scusi, la distribuzione non venga qui. Eccolo. So nice to see how all these women in Italy is not so common. To see you all talking about so important.
We appreciate the opportunity. Thank you.
Thank you very much.
We're here, and it's just going to keep happening. So.
Thank you very much for everything. Thank you very much. Thank you. Thank you very much.
Thank you.
Welcome to our next session. We're here to hear from our colleagues from Beijing who are going to be enlightening us. Too close? Once again, I'd like to welcome you to the next session. We'll be honored by hearing from our colleagues from Beijing. And our first talk will be by Wang Fenghyun on double chamber left ventricle from clinical to basic.
Thank you for your help. Thank you, the introduction of the chairs. Thank you for the invitation for the conference. It's the first time I come to Italy. I come from Beijing Children's Hospital. My name is Wang Fengyun. I'm very glad to come here to share our cases with you. My topic is double-chambered left ventricle from clinical to basic. Double-chambered left ventricle is a particularly rare congenital cardiovascular malformation that is difficult to diagnose. It is often asymptomatic and remains undetected until it is found incidentally during adulthood. First described in 1981 by Gerlis. First reported in 1984 by Kay. Compared to DCRV, and only a few cases of DCRV has been reported. The incidence of DCRV is estimated to be 1 in 36,000 patients, and the incidence of the DCRV is certainly even less. Definition. The DCRV is a extremely rare congenital left ventricle anatomical dysplasia, characterized by the subservation of the left ventricle into two chambers by the abnormal septum or muscle band. The main chamber is usually located at the base of the airway, and the mitral and aortic valves are often connected to the main chamber. The accessory chamber was mostly located at apex and the lateral wall of the airway. Excessive hypoplasia or degeneration of typical meshwork in the middle of apex of ventricle in Abra. The radionuclide and physiological examination confirmed that myocardial perfusion and metabolism was damaged. The endocardial fibrosis occurred, and the coronary microcirculation might be disturbed in the myocardial of the accessory chamber. The main chamber is located at the base, in which the size and the contractile function is normal, but it connects mitral and aortic valves. The accessory is located at the apex or the lateral wall of the airway, where motion can be reduced and even absent. The different size of the blood flow traffic opening and the ventricular function will cause different degree of obstruction of the middle of the airway. This airway could be classified into two types according to the position of the accessory chamber and the main chamber. Type A, the main chamber and the accessory chamber in a superior inferior orientation. The left is the type A, the main chamber and the accessory chamber. Type B, the main chamber and the accessory chamber parallel to each other. The right is the type B, the main chamber and accessory chamber. This airway can appear in isolation or with other heart malformations, such as AVSD, VSD, DCRV, and PVS. The treatment depends on the function of the left ventricle main chamber and the presence of abnormalities. Diagnosis. There are many diagnostic methods of the DC airway, such as angiocardiogram, echocardiography, CT, CMRI. Echo facilitates and clearly and accurately diagnosis of DC airway. It not only reveals the size, position, wall thickness, and wall motion and the communication between the two chambers, but also evaluates the function of the two chambers and determines whether which is obstruction between them. CMRI is a good adjunct to echo that can reveal the tissue characteristics and morphology and can measure cardiac function accurately. Echo diagnosis. 2D echo showed in the peroneal airway lung axis and the epic four chambers views abnormal hypertrophic muscle bundle and the fibrillary bundle was found in the middle of the airway or near the apex of the lateral of the airway. And the airway was separated into two chambers, the main chamber and accessory chamber. The accessory chamber for less than 1/3 of the total volume of the airway. CTFI showed metal-colored, slightly accelerated follow in the middle of the airway between the two chambers. This is a CT imaging of DC airway. The latter is type A. The two chamber superior inferior orientation. The right is type B. The two chamber is parallel each other. This is a CMRI images of DC airway. Differential diagnosis of DC airway includes 4 other cardiac diseases: diverticulum, aneurysm, hypertrophic cardiomyopathy, and left ventricle non-compation. This is imaging of the diverticulum. Yeah, this is an aneurysm. This is a hypertrophic cardiomyopathy. This is a ventricular non-compaction. The mandate and the echo findings of our patients. From the 2012 to the 2019, 12 patients, including 5 males and 7 females, ranging from 2 to 41 years old. We were diagnosed with DC airway by echo in our hospital. The clinical manifestation includes cyanosis, cough, fatigue, palpitation, and dyspnea. Physical examination revealed touch and feel, decreased breath sound, and weaning. Cardiac examination revealed enlarged heart borders, decreased heart sounds, and systolic injection murmurs. Other systemic examination revealed no abnormalities. All patients underwent chest X-ray and electrocardiogram and echocardiography. 9 patients underwent CMRI. Among the patients in our group, 1 died mitral organ failure 1 year after the diagnosis. The rest patients was followed up at our hospital. This is our hospital's patients, the echo and the CMRI images. 9 type A, 3 type B, and 9 patients went to the CMRI. Familial aggregation was observed in our cases. Case 1 to 5 were close relatives. Case 2 was the mother of case 1. Case 3 was the aunt of the case 1. And case 4 and 5 was the sisters of case 1. However, in our group of patients, 5 individuals in the family were diagnosed with DC airway. Oh, in here, I have something to say. The case 5 the diagnosis of the case 5 and the genetic results is after our article, finished article. So the case 5 is not included our article yet. Family showcases, we discovered a novel rare variant of MYH7, the causative gene for several heart diseases. In the patients from this family, this suggests that DCRA might be a genetic disease. The family provides a sample for indication of the pathogenic genes of DCRA, laying the foundation for further genetic etiological studies. We have another family cases. Case 6 and 7 was mother and a doctor. These are doctor's images. The mother's is showed. The diagnosis of the DCRA is detected. Compare in echo images of mothers and daughters. They are very similar, but not MYH7 genes was definited. Intensified. Sorry. In final, summarized above, there is some limitation to our study. First, the MYH7 rare variant was only identified by WES in one DCRA family with a smaller number of patients. No additional genetic evidence was found in any sporadic case or other family because of the rarity of the defect. Interestingly, a previous study of the DCRA did not identify any causal mutation. Despite testing of the MYH7 gene, this finding may indicate genetic heterogeneity of DCRA and suggest that our finding could only explain, in part, in pathogeneticity of DCRA. Second, further foundational experiments are important to determine the pathogeneticity of the MYH7 mutation and was identified in our study. In conclusion, this is the first report of the family DCRA and identification of MYH7 as its genetic case. Additionally, our results provide useful information of MYH7 associated diseases. That's all for my report. Thank you for your attention.
Thank you very much for this nice discussion. Are there any questions or comments from the audience? If not, then I think we'll move to the next presentation.
Oh, only one family. In our patient, we all do the genetic examination, but only one family is discovered genetic cause. Or they,
Did you do whole exome in all of them? Were all of the tests whole exome sequencing? Do you know, was it WES whole exome in all of them?
yeah. Yeah? I'm sorry.
It's okay.
Oh, thanks.
Yes, please. Back there. Oh. There's somebody. Yeah, she has some questions.
Hello, thank you for the report. It's not my question. I'm reporting a question here. Have you been able to explain the embryological development of this defect, especially of the type B that you presented?
Or something like that.
You may need to repeat that.
Embryology defect. Yeah.
So
Wait, please hold.
the question is if you have been able to understand the embryological development of this type of defect lesion, especially of the type B that you have presented.
Do you mean the VSD is different from the type B?
No. If the embryological development
Yeah.
has been understood, so have you looked into that or have you had the chance to assess this border?
The way our patients is the type B, our patients, the accessory chambers is mostly locate the lateral wall of the airway. It's mostly is in the septum side. Yeah.
Yes, I think we'll have to take this offline maybe later with the person, but
Yeah.
I think we'll move to the next discussion now. Thank you very much.
Yeah, thank you. OK， 拔出来直接拔了就完了。这儿吗？哦。哦，拔了就完了，来吧。
That's all? Loud? Loud. No. Okay. How to say? Oh, yeah. Perfect. No. How to examine? Yeah. I know.
Okay, our next presentation is by Dr. Li Shi-Ri, Risk Factors and Predictive Models for Intravenous Immunoglobulin Resistance in children with recurrent Kawasaki disease. Please.
Thank you, Professor. Good noon. I'm very glad to be here. This is my first time to Italy. My topic is about risk factors and predict models for intravenous immunoglobulin resistance in children with recurrent Kawasaki disease. I'm Dr. Li from Beijing Children's Hospital, National Medical Center. Now I will about 5 parts. First of all, background. Kawasaki disease, as known as MLDS, is a childhood disease characterized by systematic vasculitis. Epidemic studies on Kawasaki disease in the past 20 years have shown that the incidence of children under 4 years old in my country has been increasing year by year, and there is a certain possibility of recurrence, with a recurrence rate of 1% to 3%. There are few reports on the clinical analysis of resistance to intravenous globin in children with recurrent KD in my country. So our purpose is to investigate the risk factors for intravenous immunoglobulin resistance in children with recurrent KD and to build predictive models to help make more effective clinical decisions. Methods. Study subjects. For the patients with recurrent Kawasaki disease treated in Beijing Children's Hospital between 2010 and 2021. The diagnosed criteria for KD include classical and incomplete KD. Diagnostic criteria for recurrent KD, 2 months after the clinical symptoms and the signs of KD disappeared and the abnormal laboratory test indicators returned to normal. The disease returned and meet the diagnostic criteria for KD. Inclusion and exclusion criteria, see this picture. We can collect the gender, the age of the first onset and replaced. Clinical manifestations include duration of fever, main clinical features of KD, and the other symptoms clinical manifestations. Laboratory examination include blood routine, CRP, blood biochemistry, conclusion function, and etc., X-ray, electrocardiogram, electrocardiogram, abnormal B ultrasound. The treatment process, treatment with IVIG and other drugs at the onset and relapse. Analysis, we use the SPS 20 software to use the data. During the 12-year study period, a total of 2,125 children with KD were admitted to the hospital. 2 cases were excluded due to incomplete data, and 19 cases was finally included. 65 were boys and 25 were girls. The median age of the first and second onset was 22.5 months and 13.4 months, respectively. The mean interval between the 2 onset was 8.5 months. 15 children, about 16% relapse within 12 months after the first onset. Risk factors of IVIG resistance in children with recurrent KD. Of the 19 patients with replaced KD, 17 for response to IVIG and 16 were resistant to IVIG. Patients with IVIG resistance in recurrent KD was elderly at the first onset of the disease, has a higher possibility of IVIG resistance, and had increased CRP levels, lymph node percent, TB levels, productive time, and INR, and decreased lymphocyte counts and syndromes. This picture shows the clinical data of the different patients. This is an analysis of our data. The picture 1, the picture A and the picture B show we do different models in the training and validation correlate. This picture also shows our model is very good. In the different patients, we have a very good result. This also shows the models is very stable. This picture shows the patient with the recurrent KD. We can see some models to the recurrent KD. The conclusion, in this study, 2 prediction models for IVIG resistance in children with recurrent KD was successfully conducted and international validated. To our knowledge, this is the first study to establish and validate production models for IVIG resistance in children with recurrent KD. Thank you for your attention.
Thank you very much. Are there any questions or comments from the audience? Seeing none, thank you very much.
Thank you very much. The same.
Our next speaker is Yuan Yu. Her presentation is entitled Transseptal Approach versus Transaortic Approach for Catheter Ablation of Left-Sided Accessory Pathways in Children. Thank you.
Good noon, everybody. First, thank you, Chairman, Professor. Thank you, Professor Wooden. I'm Sam, come from Beijing Children's Hospital, same center, heart center. And today, I'm very pleased here to bring, share our experience work about children's arrhythmia intervention ablation. Our hospital started work from 2004. So until now, we have done this work for 20 years. That means I have done this work for 20 years. Yeah, ablation, intervention ablation for children's arrhythmia. So today, my topic is transseptal approach versus transaortic approach for catheter ablation of left side accessory pathway in children. My content include 5 parts. The first, background. Radiofrequency ablation is the main method for radical treatment of supraventricular tachycardia caused by left accessory pathway, we call the AP, in children. Ablation approach, usually by transseptal approach, we call the TS, or transaortic approach, we call the TA. Method analysis for adults usually give us conclusive results. TS has a higher immediate success rate and a lower late recurrence rate and complication rate. That means recurrence rate and complication rate is lower but lately. Large randomized trials and studies in children was lacking. Method, a single center retrospective clinical study, and our patient from January 13, from 2018 to January 7, 2020. All patients from Beijing Children's Hospital. My paper objective is to compare the safety and efficiency of TS and TA for left accessory tract radiofrequency ablation in children. This is an inclusion criteria and exclusion criteria, so I can read the left. Paroxysmal supraventricular tachycardia with 2 or more episodes clinically. And the electrophysiology study confirmed is the left accessory pathway. In accordance with the indication of radiofrequency ablation, and informed consent was obtained. Exclusion criteria such as the patient had surgical or anesthesia-related contraindication or complicated with severe structural heart disease or other systematic diseases. No spontaneous or induced arrhythmia occurred during catheter ablation. We use the NAVIX insect produced by American. We call it insect, yeah. NAVIX insect. Follow-up, all patients was followed up regularly at 1, 3, 6, and 12 months after operation. The patients were followed up by ECG or echo and 24-hour Holter. And 34 follow-up showed the disease recurrence and post-operative complications. Observation index include 6 parts. Success rate, the first important, and the recurrence rate, and the complications, and the left location of accessory pathways, procedure time, and the radiation dose. We use data analysis SPSS22, etc. Okay. And this is the baseline of characteristics of patients in TS and TA groups. Age, we use months, so here. And some male is more than female. Body weight, here is I want to show here. Sometimes we did this procedure for less than 30 kilogram patients. That means they have some complication with heart failure or tachycardia occurred frequently or cannot stop. So sometimes we did this procedure for the small weight patients. And the location of accessory pathways, left lateral and left posterior septal, left posterior lateral, left LAL, and so I cannot read it. LMS, etc. And the number of these different location accessory pathway here. The more frequently is LL, and TA group 32, here 33. And the result too, here you can see the success rate on this group, TS group, 100. In this group, we have 60 patients. And the TA group, we have 41 patients. And here, our success rate is 97.62. Recurrence rate and complications, both group 0. And overall, the procedure time here is significant. It means LPS, LPL procedure time on these two groups. TA spent more time. And the more important thing here is radiation dose. We call milligray. On this group, 28. On TA group, we use 0. So if we use TA measure, we never use radiation. This is a 0 radiation. This slide show us again. We can get the important results again. Comparing the procedure time of the two groups is significant. LPS, LPL on TS group is spend less time. So we get the conclusion. Both TS and TA are safe and efficacy for left accessory pathways ablation in children. TA is the preferred approach, 0 radiation, less complication, easy to master. Then where and when TS can be used as an alternative to TA? We got the experience to share with all of you. The first is the bypass is located in the left posterior wall or left posterior septum. The second is concomitant aortic disease and failure of TA. Then we will use TS. Thank you all for your attention.
Well, thank you for discussing 20 years of work. Congratulations.
Yeah, I have done this work 20 years from 2004. So I'm a little bit fight because obesity can predict the radiation.
Good. Good. Any comments or questions?
Yeah. You are so nice. Navix. We use the Navix. That means
the 3D imager?
yeah, three dimension, yeah.
Carto kind of thing, yeah.
Yeah. Okay. That's very well. Yeah. 3 dimension, yeah. Triceptal? Yeah. Sometimes we use. When we triceptal, we use the X-ray. Yeah, that's accurate. Prevent the complication. Yeah.
Please.
Yes. I want to ask you about two questions. First, these diseases are full Parkinson-White syndrome or other arrhythmic problems? This disease you described is Parkinson-White. Secondly, the minimal age of these patients were, as far as I understood, 1 year old. That is 130 months. That means 1 year old. Is that right? 10 years. 10 years. So under 10 years, you didn't do any procedures?
No.
In these patients?
Sometimes.
Under 10 years?
Under 10 years, if the patient...
After 10 years?
After 10 years.
Okay, because before some complication can occur.
Yeah.
Is correct?
Yeah.
Okay. Another question. In these children, sometimes these arrhythmic problems are combined with many different conducting nerves that are very close in children. So it's very difficult to make ablation with radio frequency on these children because of the size of the nerves. Correct? That's why you do after 10-year-old and not before. Another question?
Can you briefly give me the question?
Yeah, okay. And another thing, what were the symptoms in these children because you intervene? What are the symptoms on these children? Tachycardia, tachyarrhythmia? What were the symptoms?
Palpitation, tachycardia, headache, and dizziness.
Okay.
And face pale, something like that.
Thank you very much.
Okay. Thank you.
I see no other questions or comments, so we thank them again, and this concludes this session. I think we are ready for lunch. It's down in the courtyard below us in the next level. So we'll see you back at 2 o'clock.